Well, good morning, everyone. I'm Nigel Edwards. I'm the Chief Executive of the Nuffield Trust, and welcome to the 14th Nuffield Trust Summit. It's our second online series. Many of you will have attended either these online sessions or our in-person ones before. It's good to have you back. If you've not been with us before, it's a pleasure to widen our audience and attract people from across the globe as well, which is something we're less able to do when we were face-to-face. A few practicalities before we open the session. The Nuffield Trust, for those of you who don't know, is a health policy and health services research think tank. We look at a wide range of issues relating to health and social care policy. With the summit, we're trying to provide people working in healthcare and health policy and social care with the opportunity to sit back and reflect a bit and look forward, so reflecting on some of the current big issues of the day, but not necessarily diving into the immediate topical things that face us on a day-to-day basis, but perhaps being a little bit more strategic. After today's session, we've got some further discussions taking place on tomorrow, Thursday and Friday. The full programme is available on this platform and you can sign up at any point during the series. Tomorrow's session is on lessons from international experience on resilience and recovery from COVID, reflecting some work we've been doing with our friends at the European Observatory on Health Systems and Policies. This series is reflecting some of the pressing issues facing the NHS and social care now. Think about what's changed since the COVID-19 pandemic, and we've got themes around recovery, integration, reform of the health and social care system. And we're, as I said earlier, trying to look both medium and long term in that, and where we can, bringing an international lens to some of those issues. We've got some great speakers during the summit, so we hope you'll be able to join us. We're very grateful to people who've helped to make this happen. Our sponsors are Optum, our media partner is the British Medical Journal, and we've got a whole team working behind the scenes to try and make this a success. Each session is an hour long. You can come back and watch it again if you have to go off and do something else. And just a couple of logistics things. There's a Q&A box on your screen. Please submit questions at any point as we go along. If there's something particularly relevant as we're talking, we'll try and pick that up. Otherwise, my colleagues are going to try and group them together, and at a point later in the session, Leonora Merry, our Director of Commerce, will appear on the screen and summarise and synthesise some of those questions. So put them in at any time. We'll pick them up if they're relevant at the point we see them, but generally we'll try and corral them together so that we can deal with a whole tranche of them at the same time. At the end of the session, we'll send you a link to an online evaluation form. We're very keen on evaluation. It's one of the things that we do professionally, so please fill those in. If you just wait a moment, at the end of the session, a link to it will pop up, and that will help us do things better next time. We have a hashtag NT Summit, all one word. Please feel free to use that. We've tended to hold these on a Chatham House basis. This platform doesn't allow for that, but so please don't feel constrained about sharing what you've heard and what your thoughts on that are. So now to business. We're really pleased to have Amanda Pritchard, who is the Chief Executive of NHS EI. Previous attendees at the summit will remember that one of the highlights of the summit was Simon Stevens very skillfully failing to answer many of the questions that he was asked. Amanda is she tells me, very different, but either way, we're delighted to have her. It's fantastic to have you, Amanda. You've taken over at perhaps one of the most challenging points in the NHS's history. We can have a debate about which has been the most challenging point over the last few years, but there's certainly a big issue now. And we seem to have moved into a world in which the population, the media and politicians perhaps are going to be less grateful than they had been during the pandemic, and there's signs of them becoming slightly less content and rather more demanding. So perhaps we should start with your assessment of where the NHS is now. What are your main areas of concern, and where are the areas where you've got some optimism?
Nigel, thank you. And it's great to be with you today. I think the bit where I'm definitely different to Simon is I am much less skillful at avoiding answering the question and much more likely, I'm afraid, to actually answer the question. So let me have a go at that one. So I think you're absolutely right. I mean, my sense talking to colleagues, I mean, I've been in the NHS for a very long time, is this is a really challenging moment for us. I think the NHS has got an awful lot to be incredibly proud of, particularly over the last 2 years. I think what the NHS has done, what staff have done across the NHS has been absolutely breathtaking over the past couple of years. But we find ourselves now, don't we, in a situation where it's worth remembering we still have over 8,000 people in hospital with COVID today. And of course, what we want to be doing is now doing, I think, two big things, which is really pressing on with the recovery agenda. And I feel that when I'm out talking to people, this is not just something that the government cares about. It's something that our staff really care about, because they're seeing the impact on patients every day of just the inevitable displacement of services over the last couple of years. And it's something the public really care about. And it, of course, isn't just elective. It is recovery across all of our services, be that primary care, urgent emergency care, mental health, everything else. But the second thing is, I think people also really want, and I really want, for us to kind of get back to, that wider set of priorities that were set out in the long-term plan, which still matter. In fact, you could argue they almost matter more now, even than they did then, because some of the things the long-term plan was talking about was about outcomes. It was about shifting to prevention. It was about how we use. In fact, I would say, the last 2 years has given us so much more to build on actually in these areas. How we use digital technology to provide care differently for patients. How we use data to really understand the needs of our populations and respond to them. How we put inequalities front of mind when we're thinking about all of our services. Partnership is an absolutely fundamental, not nice to have when you can kind of get around the ICS table, but just a fundamentally, day-to-day way of working, whether that's very local, right to, how I want us to be working at national level. And of course, part of that also, the critical part, I would say, it's going to be about workforce. So we have learned some good stuff through COVID about how, you said it a moment ago, actually the level of commitment and the level of, passion people have for the health service. And we've seen that, I think, in the number of people coming forward now to join, to sign up as, to train to be nurses, healthcare assistants, to train to be allied health professionals, etc. And we've seen some of the flexibilities that have been used in COVID to allow people to use, digital passporting, working in different ways, in different places, flexibility. That we've got more staff than we've ever had before. We've got more demands than we've ever had before, and the ability to look after and support the staff we've got today, but use this opportunity to really plan for the future and take that opportunity to develop a workforce strategy that gives us a clear vision for what we're going to need for the medium and long term is going to be absolutely critical to everything else that we do.
Yes, let's pick up that workforce question. So it's interesting you mention it, and the King's Fund, ourselves, Health Foundation, have and you and others have been calling for a comprehensive workforce strategy that seems to have been a long time coming. Before we talk about that, though, I mean, you've I think alluded to something that's on my mind, which is, of course, workforce strategy isn't going to do very much about some of the issues that we have now. Because while, as you say, there's enthusiasm to come join the NHS, there's still, I think, a bit of concern about burnout, which is a problem across the developed world health systems, and COVID's probably made that worse. And the immediate need to retain people is obviously very, very pressing. Are there things that we need to be doing now, but either at a policy level, for example, issues around pensions, or more locally, or NHSE, that can perhaps help fill that gap while we wait for the impact of any strategy that we get to kick in? Because that's probably several years off, isn't it, to be honest?
Yeah, Nigel, I mean, you're absolutely right. I think, and the way that we're certainly thinking about workforce strategy is very much there's medium term and there's long term, because clearly when we're thinking about the opportunity jointly with HEE to do the long-term workforce strategy, you can bring in all of those different elements, including training numbers and look much more strategically at what it will take to give us a really resilient workforce for the long term. But we are here now, and we need something that speaks to the more immediate challenges. So I would also recognise, and I know colleagues on this call will as well, that absolutely kind of fundamental point about staff support and recognising people have had very different experiences over the past 2 years. So for some, it has been a hugely personally traumatic couple of years. For others, actually what they're asking for now is to just kind of get on and do the jobs they came in to do. So, we've got to recognise that it's not a one size fits all, and certainly my sense is anything we can do from the centre around health and wellbeing will only ever be in support of what is done locally, because that's, it's your team, it's your organisation, that really matters there. But making sure that looking after our staff remains, front and centre is going to be critical. But your point, what else can we do? So, you're absolutely right. Some really practical stuff around retention. So we are, of course, looking at pensions as one of those things and working with government on what we can do to make sure we're able to do that. Also, flexibility is another really big one, because people tell us that flexible working is important, not just in terms of kind of hours, but also being able to work across different organisations and work more flexibly in their roles, because many people, again, have done that over the last 2 years and want to continue to do that. We've also, I think, got opportunities, again, in that sort of more medium term, short term window, as we do some quite big investment in digital technology. You'll have heard, I think, the announcement about really pushing on with EPR rollout, particularly to those organisations that don't have an EPR, 45 trusts don't have an EPR, setting some quite big ambitions around that. That's the kind of thing that we know also just makes people's working lives easier. So the more we can get some of the digital technologies deployed, and I'm apologies if you can hear banging in the background, because I am working from home because there's a tube strike today, and we have builders. So apologies if there's some disruption. But just digital technology data, what can we do to make people's lives easier today? But the other thing is we've still got to attract more people to come and want to work for the NHS. So actually, one of the things we're announcing today is a big new public drive to ask people to think about enlisting as an NHS reservist. So we've been piloting this in 5 areas, 17 5 areas. So we've tested it, it seems to work, and it's an opportunity not just for people who've got some history with the NHS to want to kind of sign up and continue to be part of it or come back, but also for people who've perhaps never considered a career in the NHS to sign up. So big public announcement today, and we're looking for more of those sorts of opportunities to do things which will, as I say, get people today to want to join, to stay when they're with us, see their roles and careers as something that is going to give them meaningful work over the long term.
Because I guess one of the this is all great, and new types of staff and new roles and flexibility will make a big impact on the way that things work. But I guess there's a sort of a bottleneck around surgeons, anaesthetists, and proceduralists. And thinking back to the noughties, when there was a big push on waiting list reduction, that people were prepared to do extra sessions, work weekends, and we're expecting quite a big sort of productivity increase, aren't we, as part of the elective plan, which I think is generally an excellent, really very good plan, I felt. But the one thing that did worry me was the appetite that people have got for that additional work, and how we might, if that appetite isn't there, what happens and how can we deal with that?
Yeah, I mean, you're absolutely right. I mean, it's kind of obvious point, but we can't do anything if we haven't got the right support from colleagues across the NHS to deliver these. You're right. I think it is an ambitious programme around elective recovery, but it's a realistically ambitious programme. But it's absolutely dependent on workforce. And I think my sense, again, talking to colleagues, is we've got great support from Royal Colleges. They're really up for this, and particularly talking to people like surgeons and anaesthetists pharmacists, they're at the sharp end of seeing their patients and they want to treat them. So, my sense is there is still a huge amount of kind of goodwill and energy out there, but practically being able to sort out things like pension arrangements really matters, because that's the kind of thing that people will say, look, we want to do the work, but just help us find a way, help us find the right policy construct that just allows people then to do that. And also, I come back to recognizing that this is also, not a one size fits all answer. So some of our colleagues who've been working in theatres and anaesthetics really have been at the sharp end for the last 2 years, and obviously not only them, it's been true across the board. So the appetite will be different in different places, and I think that's back a bit to the conversation about flexibility, is finding ways locally of enabling people to do what they do want to do and what they can do, and some of the, again, sort of local support around flexibility, flexible ways of working, but also health and wellbeing support.
I mean, probably a key part of all of this is getting primary care sorted out. It's a key part of the integration of population health management agenda. Certainly something I've been doing quite a lot of work in middle income countries to prepare for the UK's general transition to being one. And one of the things that we've definitely learned there is having a really strong platform in primary care that you can then build other services on. You can create population health management systems around it. You can put in mental health and social care. You've got, if it's scaled, it's got some management capacity. And my slight concern at the minute is whether or not the platform we've got there is secure enough in terms of both its capacity to change. Trying to corral eight practices in the PCN to all standardise their systems and processes to allow them to employ these additional roles, to do that change management, to have the human resource management capability, to be able to integrate their information systems. Quite a big ask, and I know you have Claire Fuller looking at this, and it seems to me to be such a key area, and perhaps one that we've perhaps not paid enough attention to. And I just wondered what you're hoping to come from that review, and do you agree with my concerns and my diagnosis there? And if so, what might we be what might you be hoping to be seeing move in the primary care space in the next few years?
Yeah, thank you, Nigel. I think your kind of characterisation, I think, of the importance of PCNs was absolutely one of the drivers behind asking Claire to do her review, and recognising, I think, for all of us, the reality that if we want the whole system to work, and thinking about the integrated care system, then primary care is absolutely at the heart of that. And whether we're thinking about practice level, whether we're thinking about neighbourhood, PCN, place, ICS, primary care is critical to every single one of those. And finding ways, again, recognising it won't be a one size fits all answer to this, but finding ways of making sure that we are setting ICSs up, or ICBs as they will be when they become statutory organisations, to get PCNs and put the right support in place for them, was one of the kind of key questions we asked Claire to go and talk to people about, and get a clear view on how we could sort of start as well as possible with primary care at the heart of that ICB ecosystem. And I think what she's saying is sort of early findings are, that absolutely PCNs, we shouldn't forget, are still fairly young organisations. They've only been around for a short time. They've absolutely proved their worth in the pandemic, particularly around the vaccine programme. But yet, if we want to go further and make PCNs, increasingly, as you say, equipped to do things which they are uniquely sort of well placed to do around things like the additional roles, the education and support, the data, the ability to create new services at at that local population level, then that needs attention, and we do need to put not just the right policy framework in place, but also the right support on the ground to help PCNs to develop in that way. But I don't think she's going to say, I mean, look, I've had lots of conversations with Claire, but I haven't seen her outcome. But I certainly don't think she's going to steer us away from PCNs as being the thing that we absolutely, recognise at the heart of this.
So do you see the action there being a sort of place and ICB level action rather than 2 years of fractious negotiations with the GPC on the GMS contract? That's a leading question, isn't it? But never mind, I'll let it stand.
So we actually asked Claire to, in the scope of the work, kind of to just not to go to a place where we saw the contract as the answer, but to start with absolutely recognising the existence of the existing contract and what we could do within our current arrangements. And I think what she's come back with, again, early discussions, very much says, look, it is the former, not the latter, because there's a strong sense, I think, that she gets from talking to colleagues across primary care as well as across ICBs, that the vision for the future of primary care is actually there's quite a lot of consensus around it, and the value of primary care and how we achieve that does need to be less about contractual negotiation and more about actually how we get some of the things that we've now put in place, but as I say, relatively early days to get to the next level of development and maturity.
That's very encouraging. I mean, one of the things that has struck me, particularly maybe about some of the sort of public discourse on integration and the role of primary care, is that a lot of it does seem to be framed in terms of keeping people out of hospital, and and with a lot of emphasis on integration with social care. And I wondered whether it's perhaps time to redress the balance a bit and be thinking actually about developing this more integration within the NHS as well as with social care. I was pleased that the white paper recently had a little bit more emphasis on that, but there's still. I wonder whether there's more opportunities here to get perhaps using the ICSs to get the NHS's act together a bit more on integration and rebalance some of that focus and effort in that direction. Would you agree with that diagnosis, or am I being a bit unfair?
Well, so I think what we're going for is if I also step back a little bit to my days in South East London, I think we've always talked about sort of three-way integration. So, we've always talked about health and care, yes, but we've also always talked about mental health and physical health. And we've talked about kind of primary and secondary. And I think that's really what the ICBs are now, uniquely well placed to help us do. And it's what, again, we've seen people doing organically and, essentially over the last couple of years. So, talking to some colleagues, even just last night, actually, about where they see the opportunities with the provider collaboratives, a lot of that is focused on how they've set them up differently. Some are mental health only, some are acute only, some are all in. But, really identifying, where can we bear down on unwarranted variation? Where can we use workforce more flexibly? How can we use our combined assets differently? How can we tackle, planned care in a way that means you get the same access no matter where you live and which is your local hospital, because we're working as a network. So some real opportunities, I think, for that internal integration, and thinking again about end-to-end pathways. That's the obvious opportunity of having primary care in the mix as well. And then when we're talking about place, then you see real opportunities, again, developing in practice now about mental health and physical health colleagues working together as they've done for a long time, but really, baking that into things like crisis response services, and also when we think about discharge and how we get people home and stay at home. So I agree with you, Nigel. I mean, I think it's really important that we hold on to this sort of three-way integration opportunity and don't just think about this purely as health and care, although there's no doubt that health and care is a hugely important element, of course.
Good. I expect there'll be some questions on that. Just before we go to questions, just one other topic which has been a sort of perennial theme of policy conversations I've been involved in for for years, and you'll have seen, maybe haven't had a chance to read, but Chris Hammer's produced a report for the NHS Confederation, which calls, as I think he's done at least 2 or 3 times in the last 2 decades, for changes in style of performance management, of more devolution, of a different approach to the sort of culture of the NHS. I have become increasingly pessimistic with a view that anything that involves a change of culture is something that always feels rather daunting and difficult. But I just wonder what your feel is for how performance management looks like when we've got ICSs, how that fits with Jim Mackey's comments not so recently about not so long ago about perhaps a bit of a return to Michael Barber style deliverology, which I think you'll be very familiar with in terms of how that works. And this slight continuing problem common to actually again all developed healthcare systems, which is ministries of finance that suspect that health systems are deeply inefficient and unless beaten with a stick will not perform. So it's balancing very different theories of change and theories of performance management and different expectations, understandable political impatience, but with this with a strong consensus, I think over the years that people said that we do need a different and more perhaps more developmental and improvement focused approach to how we get improvement and how we drive efficiency. And we've moved away from some of the sort of more incentive market based mechanisms of that. But just give us a flavour, if you would, of your thinking on that complex of questions, if you can.
Yeah, Nigel, thank you. And look, thanks for giving me the opportunity to answer this question, because I think actually, I think as ever, Chris's input into this debate is, hugely thoughtful and, always valuable. And I think it was really good to read what he'd said, and an awful lot of it very helpful. And certainly I think one of the things that we have been doing on the operating model is working in a very open, a very transparent way, and truly trying to co-create it right from actually the moment I started at NHS EI, which was 2.5 years ago, when we were working very collaboratively with the STPs as they were then and ICSs on trying to work this through. So it feels like this is a sort of natural continuation of that work. So I guess, what do I think? I think, I am really clear that there are some things the centre has to do, is uniquely placed to do. And some of that is about being really clear about priorities, about funding. Some of the things that we again uniquely do is we can do things like convene. We can be clear about expert advice and stakeholder and convene wider national stakeholders around some of those things. We can be clear about best practice because we can gather it up and we can share it. We can be clear about allocative systems and how we incentivize reward. But we also have a kind of clear role ultimately, because it's public money we all spend. We do have a clear accountability for delivery and for assurance and for ensuring that we are putting those right kind of governance systems in place as well. So there's a range of tools in our toolbox that we need to be using as a national team, which is about how we add value to where the real work happens, which of course is not at the centre. It is going to be in all of the places we've just talked about. So it's going to be in PCNs and practices and in mental health trust and in acute trust, and it's going to be through increasingly ICBs and systems to support that local delivery. So of course we need to evolve our operating model to reflect that. And as ICBs come into statutory form, that's exactly the right moment for us to be kind of leading into it. It's why we've been working towards this over the last, as I say, couple of years. So I would say, part of the maturity that we need to get to is working out of that sort of big list of stuff that I've just described. When and how do we best deploy things like support around best practice, and how we can best do the sharing of knowledge? And we've got, again, loads of great examples of when that's worked incredibly well, and some examples of when it hasn't worked quite so well. When do we best deploy? And recognise the importance of that accountability piece that we're also responsible for. And it's an awful lot, as I say, of public money we spend. And it's entirely right. I don't think anyone would disagree with the idea that, you know, we all share, you know, particularly those of us in leadership roles, you know, obvious accountability for how we spend that wisely and what we deliver for it. But it's also, when do we deploy actually some of the power that we have to co-create and bring together expertise across the system to help advise not just on what we're doing, but also how we do it best. You know, I could keep going through all the other sorts of things that I think, you know, we have different roles to do at the centre. But my fundamental view is actually we are right for a culture change. I think the coming together of statutory organisations helps to kind of crystallise that, and the operating model needs to support and recognise that shift. And I think that this is a really important moment for us in a mature way to recognise the roles and responsibilities that different parts of the systems carry, and then together to work through how we best deploy those things so that we can be as effective as an NHS as we possibly can be, value and respect each other's roles. But ultimately, why does it matter? It matters because it enables us to come together most effectively to deliver for our patients and to make sure we're providing the best possible environment for our staff.
Thank you. Well, good luck with that. My conversation with Chris was reflected. You've got the impression I'm in a slightly pessimistic mood at the moment, but you're cheering me up fantastically. But the habit of hierarchy, the tendency to centralise power, is not a bug. It's a feature. So you will have your work cut out. Good luck with that. Let's go and get some questions from Leonora, who's now joined us. Leonora, what's been coming up?
Yeah, thanks, Nigel. We've had lots of great questions in covering issues from structure, workforce, pensions, the Ukraine. So I will obviously try and summarise and bring them together. The ones that I thought would be useful to put to you first, Amanda, is a really interesting question from James Morrow, who's actually one of our summit regular attendees, a GP in Cambridge. He's sitting there in Cambridge with two keen, bright and motivated final year medical students, and they're asking you, in the context of the productivity drive, what practical measures do you plan to implement to ensure that employee welfare is effectively safeguarded? And how do you plan to make the NHS our preferred destination rather than New Zealand, Canada or Australia? So that's quite an interesting one. And I thought I would also just add in there Rebecca Rosen, who's also a GP and our senior fellow at the Nuffield Trust, wonders if you've thought about the regulatory and appraisal burden for clinicians keeping a toe in the water of NHS work. Will you think about reducing the burden of appraisal or revalidation? So a couple there about the NHS as an employer.
Yeah, thank you. I think just because I can, I want to just come back, if I may, on Nigel's final point before I will then take your points, Leonora. But just this point about optimism or not on kind of future operating model. I think just to be really clear, I guess I slightly reject the idea that it's a binary choice. In fact, I more than slightly reject. I do reject the idea that it's a binary choice between kind of no accountability or only performance management. And I think what we actually need to do, which is why the co-creation point is so important, is get to a point where we recognise there will always be, and it's right that there will always be, a national accountability and governance around that. But how we do that, I think, is where there is a huge opportunity for change, and how we get the balance right between what all of the different parts of the health ecosystem and the wider partnerships do. That is where the opportunity lies. But I would never want to be in a situation where I sort of said, yes, it's a hard A or a hard B, because I don't believe that's right, and I don't think that's the world that we're trying to create. So just back to then the really excellent questions about kind of how do we really, what's it really going to take to make the NHS the kind of employer of choice, and how we're going to make it possible for people to work more productively, but also have really meaningful and enjoyable roles. So I hear the point about burden from Rebecca, and I think that is it's a constant review that we try and do about all of the kind of things that are in that regulatory space. I think we've done some stuff again over the pandemic where we've been able to lessen some of that burden. And one of the good questions, I think, for all of us is how do we avoid just putting it all back in now that we're coming out of the pandemic phase, and how do we make sure we're proportionate in how we do things and really learn from some of those lessons. So when we did some of the things at pace in the pandemic, we use phrases like sort of minimum governance for safety and minimum governance to make sure that we were kind of clear that we could do our kind of financial accountability as well and quality responsibilities, and sort of no more. And I think that's not a bad kind of rule of thumb for us to take into thinking about some of these things. Like so I hear exactly what that point is, and I think yes to the principles on the kind of productivity. I mean, I think again there's a huge, we spend another 2 or 3 hours talking about what's really going to make meaningful roles and make people want to work in the health service and stay. Some of the things that are important, I think. So I think there is a massively important thing about how we recruit, train, and make sure that we have a kind of modern career structure that is flexible, that allows people to come in, come out, to move between different places easily. I think we've got some again really innovative ideas from colleagues in Royal Colleges, from HEE, about education and training, and about multidisciplinary education and training, and about career flexibility. So I think that will be one thing. I think how we use things like the digital technology will be critical. So I've done ward rounds with junior doctors and seen them using literally 4 or 5 different electronic systems and having to log on to different systems. So single sign-on, single EPRs that allow people to just work at the top of their license rather than spend a lot of time just managing technology. Those are clearly things that we would expect to see real practical benefits for individuals in. Innovation, third thing. So our ability to say as an NHS that we welcome and we promote people, whether it's individuals or local teams, or it's wider than that, it's services and organisations, saying, do you know what? We've got a really good idea and we're going to do it differently. And I think we've got, again, some really kind of good, slightly more formal programs that allow that to happen. But wouldn't it be great if we could make that sort of innovation very much the sort of default way we work within the NHS? Because we've seen it in COVID and we've seen it throughout my NHS career, is when we do get that innovative response to some of those big national challenges, be they or anything else, that is often where we get really really great benefits for staff and for patients. So there's some stuff, isn't there, also about kind of terms and conditions, ways of working, pensions are part of that, making sure that we've got the right level of kind of sort of practical support around individual roles. And I think retention clearly feeds into that very strongly. And then of course there is something for me about making sure that this focus on health and well-being and people having meaningful roles and being supported as individuals isn't something that is just for COVID. It's something that we now absolutely build in, as the people plan consistently has said, to how we work, so that we are setting ourselves the ambition to make the NHS the best place to work. And my final point, Nigel, I'll stop, is I also think, let me not pretend to have all the answers. And where we have organisations that have been most effective in answering exactly this question, they haven't tried to answer it themselves. I think Milton Keynes is a great example. They have asked their own staff, what is it that is going to make this the best place to work, and then been very intentional in making changes to respond to the things that they get back as feedback.
Thank you. Yeah, and one of the as I'm listening to that, lots of really interesting things in there. One thought that does come to mind is that the innovative systems that we've got in this country, and we look abroad at say the way that technology gets adopted in Germany or France, and we look at sort of rewarding places to work. One of the common things is headroom. Is having a bit of space and a bit of spare resource to adopt a new technology or to be able to work on a new process or change. And of course, over the years, consultants have had their SPAs taken away, and the NHS, of course, spends all of its money right up to, and often more. So the ability to actually have a little bit of time and space to innovate, I think is certainly something that, if you look, you mentioned Milton Keynes. I think I was in Wolverhampton a couple of weeks ago, again, done some very, very innovative things, but they've had to create the headroom to do it. They've had to sort of to find it. And of course, not all organisations are in the position where they can do that. Leonora, back to you.
Thanks, Nigel. Yeah, quite a few interesting questions here on structures, which I'm going to try my best to summarise, but obviously very much in people's minds at the moment. So David O'Hagan, who's a GP in Liverpool, has got a couple of interesting ones here. So is it possible to combine a national health service with local accountability? It's been tried several times and each model has demonstrated the difficulties in different ways. He also asks, is the best model for an ICS coterminous with a local authority or regional directly connected to NHS England? And then on a similar theme, Hamish Dibley from an organisation called Bearing Point is asking, be interested in your thoughts on the appropriate balance between the centre setting priorities and actively encouraging local healthcare systems, the economy to innovate around understanding and improving services for patients.
Yeah. Thank you. I've now noticed that Nigel has a very effective technique of just having the final word on a topic before then asking the question.
You've spotted that, have you? Yeah.
I've just spotted that. And I'm not sure that I'm going to let you get away with it, because I think
that's okay.
Not that in any way I disagree with your point about headroom, but I also think so my sense is, in the 73 years of the NHS and my 20 plus years, change has been a constant, and the idea, in a sense, that we can ever really just carry on doing more of the same, I don't recognise that. I don't recognise that ever having been how the NHS works. So there's no doubt that sometimes having the kind of formal structures in place locally that allow you to innovate or test, proper improvement programs or whatever, can be hugely powerful. But I guess I would say my experience is, it's sort of avoiding getting into a sense of a binary choice between more of the same or create headroom for change. I kind of think change is the constant. And actually, what I've seen done incredibly well across the NHS is people, whether it's just building it into people's jobs, or it's creating more formal programs for change, or it's using opportunities like ICBs and some of the kind of additional capacity that's bringing to make sure that headroom is a feature of how we tackle some of these current challenges, because I don't think it works otherwise. So my sense would be to say, let's again avoid trying to make it an either or. It can't just be more of the same or change. It's got to be change, because that's the only way that the NHS has got through where it's got through over the last 73 years. And I don't think that's. I don't think we should try and move away from that. So your question though was on local accountability, boundaries, and sort of central versus local priority setting. So it's going to be, I think, a really important point that we try and sort of hold on to in all of this discussion about place and also kind of local arrangements, that I think we don't blur the boundaries on accountability. So people absolutely still have line accountability, and that's what the white paper describes, through existing routes. What we then are clear, what you are trying to do is then bring together people who recognise that they carry different accountabilities, and then in a sense, of course, they're sort of serving different populations and different public service together to do exactly what your third questioner described, which was then identify what the local priorities are that are really going to make a difference to that population, and combine around those sets of local priorities, as well as the national priorities that are relevant, combine expertise, in some cases resource, and in other cases it will be about actually collaborative approach to those challenges. And I think my sense is that works best when people are really clear about purpose. So sort of trying to do governance for its own sake often doesn't quite work, but trying to do collaboration and accountability for making a change that has a benefit to a population, that's where we really see things start to fly. I think we've seen that repeatedly over COVID, but also again, I went out recently, visited actually up in Leicestershire, some of their work that they've been doing on local crisis response, which is absolutely integrated across health, community, and also local government, and that team structure is absolutely designed with a purpose, and you can see the energy, you can see the difference it makes. People are clear what their line accountability is, but they're clear where they come together and how they also pool resources around a specific team with a specific purpose. And that for me is going to be the sort of some of the things that I think are going to be key to making this work is purpose. Why are we doing this, and making sure that that clarity about kind of local priorities, national priorities is there. What's the balance? So there are certain things, aren't there, that they're national priorities because they matter to everyone. And when we talk about things like elective recovery, or we talk about mental health waiting times, or we talk about crisis response services, that doesn't not matter in Cornwall and matter in Northumbria. It matters everywhere. So I think that the challenge is probably not, again, to say it's either national or it's local. It's going to be recognising that those national priorities are national priorities because they matter to everyone, but it's the how, which is going to look different in different places because of the nature of the local populations and, of course, the nature of the public services in that place and voluntary sector as well. But it's also going to be the opportunity to look at what else really matters. So the how, because they might be targeted around particular populations or particular ways of running services, but also the what. And I think, again, we've got some great examples. I know they always get cited, but West Yorkshire, absolutely leading the pack in some ways on identifying what kind of really matters to local populations and organising around that as well.
Before we go on to the next question, let me just follow that up, because I noticed in my diary that the Secretary of State's got a meeting on another white paper. I was at one on Thursday of last week. There's another one tomorrow. This one's on reform. Does that have implications for the system you've just been describing? Do you have any thoughts on what you're hoping to see in either this, the slightly unusually named disparities white paper? We don't apparently use the word inequality anymore, or the one on NHS on NHS reform. Is that likely to be congruent with the overall direction? Are you concerned in any way that we'll see a sort of shift in some of what you've been describing there, or do I not need to worry?
Right, so you absolutely would not expect me to say what may or may not be in the Secretary of State's mind on reform. That is very much, of course, for him.
I can try.
At moment. What I will say, though, is having worked very closely with him and his team, there is an absolute recognition that, of course, what we're talking about at the moment is an awful lot of reform already happening. So, the health current legislation isn't even through yet. And some of the reforms that we have talked about in relation to things like delivery of the elective recovery programme, that's just as one example, requires, a huge amount of change and transformation. So I think, number one, absolute recognition that this is already on the back of a huge amount of change and transformation and reform already. And number two, absolutely recognising then that anything more needs to fit and will fit absolutely within the structures and the direction of travel that's already in place. But I think one thing I can say, because he's already said it, is we know that the Secretary of State quite rightly is very committed, for example, to cancer. and wants to go further, faster, wants to ask the question, how could we build on what is already in the long-term plan, which is ambitious in its own right, and a real kind of call for evidence on what some of the innovation might be that would help us go even further on earlier diagnosis. And that's the kind of thing that I think I would be looking to see more of in future. So hopefully I can reassure you slightly on that point, Nigel, but without giving anything away. And in relation to the disparities white paper, I mean, again, we have an inequalities team working in the NHS, and Bola Owolabi leads that brilliantly. Bola, I think, is very clear about the things that are absolutely in the NHS's gift around inequalities. So we've got that built into the way we're thinking about things like elective recovery, and I know that resonates strongly with colleagues across the NHS. We've got that built into the way we're now thinking about data and what kind of data we capture and how we share data, and we're doing that now nationally, making sure inequalities data is sort of part of all of our board reports, for example, and we're doing that in a number of other ways very practically with things like the Core 20+5 initiative. So trying to be really clear what's ours as the NHS, and then what's our contribution to, of course, that much wider disparities agenda that no doubt you were talking about last week.
Great, thank you. Leonora.
Yeah, a couple of questions here on the role of the patient. So experience during the pandemic demonstrated the importance of ensuring that people have the tools to manage their own health, so lateral flow tests, for example. But yet most patients in the NHS are still unable to view their own electronic health records. So where does patient empowerment fit into the plans for the recovery? That's from Angela Coulter, who's a health policy analyst. And then quite a nice one from someone called Jean Ellis. What small changes can we make to listen better to each other and to the patient?
Look, thank you. I mean, these are hugely important questions, and I think it's not a coincidence that when we look at the elective recovery plan, of the four big elements, patient empowerment is one of them, because recognizing that this is not just about the NHS doing stuff to patients or for patients, or it has to be about with patients. And the more that we can use, Leonora, I totally agree with the question about the more we can use transparency and let people see their own information, that is going to be one of the kind of key building blocks of that. So you'll have seen things like the My Planned Care website, which has just again been recently announced and set up. That is directly in response. We work with some brilliant patient groups and voluntary groups nationally, very much in response to the things that they have been telling us. People are worried, they don't know how long to wait, they're likely to wait, and they want that to be something that we're much clearer about, much more transparent about. That's what My Planned Care has started as, but now they're telling us they want, quite rightly, to see that platform expanded, so it's much more about providing also local health advice on how to access local services, as well as how to sort of stay well, etc. Where do we want to go with that? I mean, long term, I think a lot of this is also about how we use the app, given that again we've got sort of huge uptake of the app, mainly driven by things like access to the COVID pass, and now we have an opportunity to make the app over time, because these things don't happen, really useful go-to place for the population around accessing their own information, but also wider health advice and navigating their way through the health system. So loads going on the kind of digital side around this. But I think worth saying that the third question on listening better, and is the other part of this, because digital is absolutely game changer in a lot of this, but we're always thinking about digital exclusion as well, and we're always thinking about that as only one of a whole number of different things that clearly matter to patients. So really, other end of the spectrum, the other thing that's actually been some of the success story of COVID has been around personalised care. So we've seen actually the LTP targets on personalised care massively exceeded over the pandemic. And part of the principles of the whole personalised care work is, don't ask what's wrong with a patient. Ask, what they need, and changing the way that we think about the dialogue, the importance of the partnership of the shared decision making, that whole personalisation agenda. Just after talking to Rachel Power last week about shared decision making board that we're just setting up in NHS England, to try very much to take those principles with colleagues and say, how do we, exactly as your questioner asked, make that listening better, shared decision making something that we build into everything we do, rather than have it as a programme of work that sits sort of particularly in any one, two or three different places.
Right. Thank you. Shall we touch on global crises, Leonora? I think we had a few questions on.
A couple of questions in here. So a sort of general one from Rowan at the Nuffield Trust. So the world's attention is rightly focused on the humanitarian crisis in the Ukraine, but the rippling effects are likely to be global and diverse. Are there potential serious implications for the NHS following Russia's invasion of the Ukraine? And also James Illman from the HSJ is asking specifically about the story that the HSJ published yesterday about 11 trusts paying over £4 million to a Russian government-owned energy supplier. And he says, given the conflict in the Ukraine, should the NHS still be buying gas from Russia?
There was also a story in the HSJ yesterday about cyber security, wasn't there? I think, which is perhaps another potential concern. But,
So, look, thank you. And I know that the Ukraine will be on a lot of people's minds, and certainly I was talking to our Jewish staff network yesterday, and again, people very much drawing the parallel between what they're seeing now happening in Ukraine and what people have. It brings back. I think it brings back a lot for people about personal experience or things that they have in their past, or some of the wider conflicts in the world, and how you're absolutely right, we are none of us immune to that. So I think three things worth saying. One is what does it mean for us? So first thing is support for our staff. So we do have staff who are from the Ukraine. This is about, I think, wider support for all of our staff, including anybody from Eastern Europe or Russia. We have had, I think, again, an outpouring of support locally for people whose families might be affected by this or who are worried themselves. So the more that we can do to make sure, and the government have done something as well around visas, and they've publicised that, but the more that we can do to provide both practical and emotional support for staff who are affected by this, obviously that's got to be top of mind. You've mentioned cyber, that's the second thing. So again, we have written out to the NHS a lot of it is just the good practice you should be doing around cyber security, but again, this just kind of brings it to the forefront. And I think for those organisations who are still just working through some of the patching and other things, certainly just encouraging people to give focus at the moment. And then the third thing, and I think that's your point, Nigel, actually, it's also about our supply chain resilience. So we're doing some work nationally with SCCL, looking at supply chain resilience. Energy resilience is clearly kind of part of that. So that is definitely the third area of focus. At the moment, I think there is... final thing to say, probably, there is a question that we're also asking ourselves about what can we do to help. And part of what we have been doing is looking at things like whether we have got any sort of flexibility around supplies, for example, which we can make sure are then made available to be provided over to the Ukraine. So particularly medical supplies that can be used to support casualty. The Ukraine, obviously, that's something that's being done again cross government, so playing our role in that as well. And I'm sure people again would want to know that the NHS was playing its role.
Thank you. I've been working with WHO in Ukraine for the last 3 years on health services reform. Not required anymore, unfortunately, and my skills are not that useful for what they currently face. So it's a difficult time for them all. Thank you for joining the session. Thank you, Amanda. You have answered almost all the questions, so you've succeeded on our criteria. So thank you for that. It's been really fascinating, and you've left me encouraged. You'll notice I started not feeling so good. I'm feeling much better. Thank you for that. don't forget the evaluation form, everyone. You'll be directed to that after the session ends. Tomorrow, we're doing health system recovery and resilience, using some lessons from international learning. Thanks again to the team who've put this together, and to our sponsor Optum and media partner BMJ. And you'll be able to watch this again on our website very soon. So thank you all again, and we look forward to welcoming you again soon. Goodbye.